So from the nephrology, we'll go to more endocrine. So endocrine is a disorder where there are a lot of miscellaneous kind of questions that are being asked in the EDIC 1 and both in EDIC 1 and EDIC 2. They're basically more clinical oriented. So we usually get get MCQs on all fronts of the endocrine topics like thyroid, adrenal disorders, pituitary disorders, hyponatremia, all sorts of. So we'll try to cover. So I have half an hour probably. So we'll quickly go through and we'll mainly do the MCQs because they are the rapid course. I hope you can, so everybody can interact with me and during the entire session. So at any point of time, anybody has any question, you can just interrupt and ask and interact probably. That will be a better way to continue this class. Is that okay? Hello?
Yes, sir. Yes, sir.
Sure. So we'll come to the first MCQ. So again, just read out the MCQs and then we'll just answer and then we'll have a short discussion. So this is 36-year-old woman came with a weight gain, dry hair, skin. Her TSH is elevated, thyroxine levels, free thyroxine levels are a little low, and other blood tests are normal. So what are the most likely diagnoses? Very simple question. Most of the time, so in EDIC 1, what happens, almost 60-70% of questions are kind of easy questions. Not very tough, not very controversial, but there are 30-40% always kind of little controversial. So very straightforward question. So what is the answer? Anybody? Anyone? No one? When is your EDIC 1 exam? Which date? Oh, I'm getting answers in the chat box. You can just unmute yourself and then talk also. D, Pradipta Sengupta D, yeah, C, which is okay. Okay, let's not waste time because wasting time is not an option. So answer what is so what you can see over here. So this lady has come with hypothyroidism. Her TSH is elevated, FT4 is low, so that means she is suffering from hypothyroidism. So what is the commonest cause of hypothyroidism in a woman? It is autoimmune thyroiditis. The most common is in this age group, 36-year women, is Hashimoto's thyroiditis. It is not Graves, it is not toxic multinuclear goiter because they are all features of the hyperthyroidism. So it is Hashimoto's thyroiditis. Is that okay? Any response?
Yes, sir.
Okay. So very straightforward question. Usually there should not be any doubt for this kind of questions because they are very straightforward. Now, how do we evaluate? To have a kind of brief overview, very brief and very short. So anybody who comes with a thyroid disorder, first thing that we check is the TSH. If the TSH is elevated, then we see that whether we check the thyroid hormones T4 and the T3. Usually we prefer to measure free T4 or free T3. If the T3 or T4 is low, then it goes in a favor of primary hypothyroidism, that means a thyroid disorder. And if T4 is elevated in the presence of high TSH, which is a little unusual, but that can happen in some pituitary cause, hypersecreting pituitary tumors or something like that. In hyperthyroidism, usually the TSHs are low and the T4s are elevated. So that is a diagnostic of hyperthyroidism. But sometimes the question comes on the subclinical hypo or hyperthyroidism. That means when your TSH or TSH is abnormal, but your free T4 or T3 levels are normal. So that tells you it is a subclinical hypothyroidism or hyperthyroidism. So it's a basic algorithm that everybody should remember. So the very common causes of hypothyroidism, everybody knows. I'm not going into that thing because it's the most, we'll do more MCQs today. So second MCQ. A 58-year-old male, there's a history of untreated hypothyroidism presented to the emergency department after being found on the floor in his apartment confused. His heart rate is 52, BP is 96/40, his respiratory rate is around 12, he's confused. His auxiliary temperature is around 82 degrees Fahrenheit, sodium is 132, potassium 4 and 4.1, creatinine was 1.5. Creatinine phosphokinase is 20,000, TSH is 97. Now, given the likely diagnosis, what is the first hormone to administer? So this is one of the very popular question in EDIC kind of exam, because this is one kind of emergency situations we are dealing with. Very sometimes we see. So first thing to understand that to answer it, we should know what is the diagnosis over here. So what is the diagnosis over here? There is some chat box I can see over here.
Myxedema coma with rhabdomyolysis.
Very good. So it's a myxedema coma with a rhabdomyolysis. So what is the first hormone that we need to administer in myxedema coma? Is it steroid, thyroxine, glucagon, ACTH, vasopressin? What is the answer?
Thyroxine, a small dose, and followed by steroid.
So
Steroid.
Answer is, it is always steroid first, followed by thyroxine. Why? Because most of the time, myxedema coma, it's a clinical syndrome, and sometimes they are associated with some form of hypoaldosteronism and hypocorticolism. In that case, if we give thyroxine first, and if we do not give steroid, without giving steroid, this kind of patient can go into adrenal crisis, because thyroxine will metabolize the existing cortisols in the body, and that will precipitate the adrenal crisis. So always give a 100 milligram of hydrocortisone bolus before administering thyroxine. That is the mandatory thing. Sometimes normally what we give in a patient with that Addisonian crisis, in a patient with the myxedema coma, we give oral thyroxine, because the IV thyroid, IV T3 is not very commonly available so far. So we give a oral thyroxine, oral T4, and at the same point of time we give hydrocortisone as well. So oral thyroxine takes some time to get absorbed inside the body, get converted into a T3 and then act. So before that, if we administer hydrocortisone, then it makes a perfect balance. But sometimes nowadays we get IV levothyroxine, IV T3. In that case, if you give IV levothyroxine or IV T3 first, or even concomitant with the steroid, it might precipitate the adrenal crisis. So it is very important, if you are using IV T3, then always at least 10-15 minutes before you give a IV hydrocortisone, and then after 10-15 minutes you give IV levothyroxine or IV T3. So that is very important to know, and it's very, very favorite question in the EDIC kind of exam, because this is one of the real critical care emergency. We'll not go in depth of the myxedema coma, but most importantly, we should know what are the treatment protocol. Most of the time we give T4, loading dose of around 200-400 microgram of T4. Sometimes if you get a T3, then we can give a 5 to 20 max of IV thyroxine. But most importantly, as an initial therapy, the steroid is always our initial therapy of choice. Question number 3, what is the commonest hormonal pattern in sick euthyroid syndrome? Again, sick euthyroid syndrome is very commonly asked in all kinds of critical care exam, be it in the AD, be it in the even the DNB exam, some other MCQ exams in the DNB. So we should know what is how do we diagnose sick euthyroid syndrome. So what is the commonest hormonal pattern in sick euthyroid syndrome? Anybody? A, B, C, D, E. There are a lot of combinations are given. Anybody?
low T3, low TSH, low T4 with low reverse T3.
Okay. Anybody wants to differ, or everybody will go with C? Let's see. There is something in the chat box. Abu Mo has told A. Dinesh has told A. So the answer over here is A. Why? What is sick euthyroid syndrome? Sick euthyroid syndrome is an entity, but what happens, there is no intrinsic thyroid problem, but it happens in the acute severe illness. Most important thing to understand over here, to understand the sick euthyroid syndrome, what happens, there is two kind of dehydrogenase that makes the conversion from the thyroid globulin into the T4 and the T3. What happens over here? Yeah, the normal T1 dehydrogenase, they are down regulated, and there are up regulation of the T3 dehydrogenase. So instead of T4 gets converted to the T3, it gets converted to the reverse T3 by type 3 dehydrogenase. So in sick thyroid syndrome, to diagnose it, the RT3 will always be elevated and T3 will always be low. So if you go through all this permutation combination, first thing that you need to see whether RT3, what combination where RT3 is elevated. It is only A and B. So, and in sick thyroid syndrome, T3 is low. So without saying any other things, we can diagnose sick thyroid syndrome if there is increased RT3 but there is a low T3. TSH and T4 usually they vary. The TSH may be normal, maybe abnormal, maybe elevated, maybe low. It doesn't matter depending on the severity. T4 usually remains normal, but sometimes in prolonged sick thyroid syndrome, even T4 also gets low. But the diagnostic criteria to sick thyroid syndrome is there has to be low T3 and concomitant increased reverse T3.
Sir, why is reverse T3 increased?
Because I have told this, because there is a in sick, whenever there is a severity of illness because of the cytokine effect, there is a down regulation of type 1 dehydrogenase, which is a normal enzyme, and concomitantly there is a up regulation of type 3 dehydrogenase, which favors conversion of T4 to RT3 instead of converting to normal T3. Okay, so that is the pathophysiology.